Welcome to Rush Back Safety and Transfer Training. My name is Cheryl Wozni. I'm a physical therapist here at Rush Hospital. We're going to talk about anatomy, posture, transfer training, clinical and non-clinical protection of your back. With your back safety, why do you care? You care because if you injure your back at work, there's no guarantee that you are ever going to be 100% again. So your best bet is to prevent an injury before it happens. Why does Rush care? Rush doesn't want to see you injured, Rush doesn't want to see the patient injured, and Rush doesn't want to have a huge outlay of cash for workplace injuries and compensation. With the back safety training, a lot of what we're going to talk about, you already know. It's a matter of putting it into practice every day. With your back, we want to look at the anatomy of your spine so that you have an understanding of what it is you're trying to accomplish. Your back has 3 curves. They go in at your neck, out at your mid-back, back in again at your low back. You have discs in between each of those vertebrae to help offset the pressure. When we're talking about good posture, we're talking about maintaining those 3 curves in order to prevent injury. If you end up in a poor posture, you put strains on the discs and on your back that it's not designed to handle very well. It's much better if you can stay in those 3 curves, and we're going to show those 3 curves when you're doing different activities. If you end up putting an abnormal strain on your spine, you may end up with a disc bulge that will put pressure over onto one of your nerve roots. Take that out. With the discs are designed with a ring, layers of rings around the outside, and the center is a movable nucleus. If you spend a lot of time in a sustained forward bend, you are going to encourage the nucleus, the movable center of that disc, to move toward the back. There is less ligamentous support for the disc along the side of the disc toward the back. If you're in a sustained forward bend, you're going to push the center of that disc out towards your nerve root, and that is going to give you pain down your leg. So if you're looking at the curves in a person's spine, they have the curve in at their neck, out at their mid-back, and back in at their low back. Okay? If Erica does not have proper posture and she's a little bit slumped, her chin is going to tend to poke forward, and that is going to put a lot more strain on the discs of her neck. If she's in a little bit more of a pelvic tilt, she's going to have more strain at her low back. If Erica goes to lift an object and she bends over just with her knees straight, she's going to put a lot of strain on her low back. Go ahead and come back up. So if Erica is going to be doing lifting of patients, if she's going to be helping patients transfer, if she's going to be lifting just a box off the floor, we want Erica using her legs to do those objects. If Erica is going to pick up this box off the floor, we want Erica to take a wide stance, bend her knees, go down into a squat with her back straight, pull that box close to her, and stand up with her legs. That way she's protecting her back. A lot of the times, nurses tell us, well, the patient transfers so much better for therapy than they do for us. And there's a lot of reasons that that might happen. One, the therapist will help the patient get into the chair. The patient might be fatigued, so they have a harder time getting up afterwards. The patient might have a decrease in medical status, any number of reasons. The other thing that happens is when a physical therapist helps a patient to do anything, we are making sure the patient knows the expectation and that we break it down step by step so that we can have the patient follow through. If the patient does not understand what it is that you want them to do, you're not going to have a very good chance of them doing it. If a lot of the time we will have a patient who tells us, well, 4 nurses came in here and they just started pulling on me and I had no idea what they were doing. Well, of course you're not going to be very successful. So from a nursing perspective, you want to be sure that 1, the patient knows what it is that you expect them to do, and that you're being very clear that you expect the patient to work at their maximum capacity, and you're just there to pick up the slack. You're just there to help them. Never ever tell a patient, I'm here to lift you, because the patient will think, well, I don't have to do anything, that nurse is here to lift me. So make sure that the patient understands that you expect them to work to their maximum capacity. The other thing that a physical therapist will do before we ever move a patient is we're going to ask that patient, how do you do in your normal life? If a person is normally completely independent, they might have just had a little surgery, they might be on a little pain medicine, we're going to expect, okay, they might have a little bit of trouble. If the person tells us, I haven't walked in 10 years, I'm a Hoyer lifted to the chair, well, I'm not going to expect that person to be able to get up and walk to the bathroom. So know the base level, the prior functional level of your patient. When you're helping a patient to move up in bed, you really want to, A, make sure to use the functions of the bed that will help you, and B, ask the patient to do as much for themselves as they're able. The goal is not for the nurse to lift the patient up the bed. The goal is for the patient to do as much as they can for themselves so the patient will get stronger and the nurse will not have to work as much. So the first thing you want to do is put this bed in Trendelenburg. The new beds that they've ordered for the hospital are fantastic, that they have a really wonderful Trendelenburg function. And the patient is going to be upside down and gravity is going to help us a lot. The next thing you're going to do is ask that patient to bend their knees up, and you may have to help them. Even if they can't push very much with their knees, when you bring their knees up, then you're already helping them move up the bed some. You want to make sure you take the slack out of the draw for two reasons. One, you want to decrease the shear on the patient's skin. And two, if you try to move somebody up the bed with one person having the slack out of the draw and one person not, you will not have a coordinated effort. You want to go ahead and move the bed rails down so that you can get close to the patient. Okay? You're going to tell the patient on the count of 3, you want them to lift their head and boost up the bed. If there is a headboard on the bed, they can reach their arms above their head to grab the headboard to help. Good. And so they have used their legs to help the person to help with that transfer, to push the weight shift, and they've allowed the person to help themselves. If you'd like to help the patient to roll in the bed, you want to have the patient help themselves as much as possible. You're going to break down the component movement as follows. You're going to ask the patient to bend up their right knee. Okay. Ask them to reach across with their right arm toward the top bed rail. And then you're going to help them at their hip and their shoulder to complete that roll. So you're asking them to do as much for themselves as they can. At this point, we're going to have the patient move from laying on their side to sitting up on the side of the bed. So we need to drop the bed rail. You're going to ask the patient to move their legs off the bed so they have a counterweight, and then push up with the bed rail, help them at their shoulders. If you have a patient that requires more assistance, it's exactly the same motion. You're just going to scoop behind their shoulder and help them more. And then you're going to let the patient sit on the side of the bed for a moment or two to make sure that they're not dizzy. A lot of our patients that have surgery will have problems with orthostatic hypotension. They'll have a blood pressure drop when they first sit on the side of the bed. And you want to allow their body a chance to adjust to this position before you try to move. The last thing you want to do is try to stand a patient who's extremely dizzy and have them pass out on you. If the patient is dizzy sitting on the side of the bed, you can ask them to tap their toes like they're tapping to slow music so that their calf muscles will pump those veins and push that blood back up to their heart and their brain and clear that dizziness a little faster. And that's enough. You're now not dizzy. Okay. If we're going to have the patient transfer from the bed to the chair, regardless of how I think that patient is going to do, I'm going to put a transfer belt on them every time, because they might end up having a problem halfway through the transfer. If I have a transfer belt around her waist, I have control of her center of mass, and I can put her where I need to put her for her to be safe. When you're setting up this transfer, you want to set yourself up for the least amount of problems as possible. You're going to look at the environment. You're going to make sure the chair is close to the patient. If she has difficulty midway through that transfer, you're either sitting on the bed or you're sitting in the chair. She's not going to the floor. We're going to make sure the brakes are on the chair because we don't want that chair to move. If this particular patient requires more than one person to assist them, you will have one person assisting from the front, the second person will assist from the back. And I just want to show something now. Okay, you'll focus back on me. When the person is in the front doing the transfer, you really want to take as much control of the patient as you need to, and then allow them to do more for themselves if they prove reliable. I am going to always scoop in front of the patient, getting a hold of that transfer belt. My knees are going to be on either side of her knees, so that when I pivot transfer, I am shifting my weight from one foot to the other, and in that way, I'm not twisting through my back. Okay? So I'm going to pivot. The patient's in front of me. I'm going from one foot to the other. Okay? My back is in a neutral position, and I'm doing that transfer with my legs. Okay? A lot of nurses, I see them trying to transfer a patient, and they're all arms and back. And that's not the best idea. If you can use your legs, you have a lot more power in your legs than you do in your arms. Okay? You can get that person where you need them to be. Okay? So Mildred is going to transfer our patient. We're going to ask that patient to reach around Mildred's waist. Okay? And then we're going to make sure that patient leans in. As soon as they lean in, they're starting to do the transfer, and we're going to pivot her around and sit her. Okay? Now, if she did not make it all the way to the back of the chair, the two therapists could go one on either side and help her boost back. Of course, our patient is super long in the leg, and she's already back there. A transfer aid that's sometimes used is called a transfer board. If you have a patient who, for whatever reason, is unable to stand on their feet, or they require too much assistance to do a pivot transfer, you might use the transfer board, the sliding board, in order to do that. The key with the sliding board is the patient must keep their shoulders over their hips. If they lean backwards on that board, they could slide their hips off the board and end up on the floor. So with the board, you're going to lean the patient to the side, tuck the board up underneath her thigh, and make a bridge between the chair and the bed. It's always a good idea to have a second person to assist. The second person is going to make sure that board does not slide. You'll ask your patient to help transfer themselves over by using their arms on the bed and the board, and just slide down that board like they're sliding down a church pew. All of our patients, for the most part, have been up and down a church pew more than one time in their lives. Okay, so you slide over, scoot them back, get the board out. A patient who has paraplegia may use a transfer this way. A patient who has foot wounds that the doctor does not want them putting weight on their feet may do the transfer this way. A patient that just requires an enormous amount of assistance to do the standing transfer, you may choose to use the board in order to make life a little bit easier. Despite your best intentions, sometimes when you're moving with a patient, the patient will start to fall. Should you try to hold that patient up? You're not going to fall on me. No, you should not, because you might get hurt, the patient's going to get hurt. What you want to do is control that slide with the patient coming down toward the ground. Just control that and allow them to come to the ground so that, yes, they're on the ground, and yes, there's a lot of paperwork, but no, the patient is not hurt. Okay? And you are not hurt. And then you're going to get a lot of help, and you're going to help get the patient up off the ground. So first things first, you're going to check to make sure that patient is fine. Okay. Then you're going to call in all your little helpers that we're going to come in. You're going to assist the person to sit up into long sitting on the floor. Okay. At this point, you're going to have the person bend their knees. Okay. One person will come in front to hold the person's feet in place. You'll have one person on either side to help get that person up on their feet. 1, 2, 3, stand up. Okay. Okay. An additional person would be useful to be close by with a chair, so as soon as that person's on their feet, you can sit them in a chair and recover from there. A lot of workers at the hospital are not in direct patient care. They might be clerical staff. As you can see, Erica has lost her 3 ideal curves of her spine. So first thing we'd want Erica to do is sit up a little bit taller, okay? And think about that curve inward at her low back. The adjustable chairs that we have at the hospital, the seat pan will adjust to tip forward slightly. So we'd like to tip the seat forward, okay? So Erica's feet are flat on the floor. She lowered the seat, lift your hands up, Erica, in order to have her feet flat, okay? The way we've tilted the seat pan, it will actually encourage her pelvis to tilt forward, okay? So the seat is going to help her sit with that ideal curve in her low back, okay? Initially, she had quite a poking chin, okay? Now she's going to sit in a neutral chin position. When she's ready to type, her elbows are going to stay in close to her. The keyboard is going to be close to keep a neutral position of her wrists so that she will not end up developing carpal tunnel or any other repetitive strain injury. If, after a while, Erica becomes fatigued, she can take either a commercial lumbar roll or just a simple rolled up towel and tuck it into her low back to take up that space to help support her low back in the ideal curve. As a clerical worker, you don't want to spend your whole day in one position because you'll end up with strain injuries. Periodically through the day, every 20, every 30 minutes, just get up, go get a file, go get a glass of water, come back to your chair. If Erica was dealing with a lot of papers in her work area, she does not want to twist through her back to reach. She wants to turn the whole chair so that her back comes along with her. So hopefully that gave you some good ideas about protecting your back in the workplace. One thing you should be aware of, if you feel at all that you have injured yourself, you need to go on down to Workforce Wellness and become evaluated by the nurses down there. They're going to make you pee in the cup. It's going to take some time out of your day. But if you have really hurt yourself, you really need to have that documented so that you can be protected for the long term. If you have, as nurses, if you are wondering, why does this person transfer so great for therapy and they won't do a thing for me? Feel free to come into the physical therapy treatment and see how it is we're moving that patient, because maybe we're telling them something to do that you're not telling them. We're cueing them some way that you're not aware of. Always take the opportunity to have that person who's doing that skill maybe a little better than you to show you something. And hopefully you will not injure yourself, because at the end of the day, this is only a job. You have your life that you're going to need to carry on with for the rest. If you hurt your back, you might not be able to do those things you want to do. You're gardening, you're playing with your grandbabies, hiking the Appalachian Trail, whatever it is that you want to do. So protect yourself and try to protect your patients.